Okay, so thanks very much for having me here today. I have been in this lecture theatre before. 3 years ago, it was my very first interview that I ever had after I wrote a book, took place in this lecture theatre just before the book came out. And I vividly remember the sheer terror that I experienced as I sort of took my place in this position. And I was shaking so much I really couldn't control my voice. My voice was cracking up. My face was turning that sort of colour of red that only a sort of red-haired Irish person's face can really turn. And basically, I realized at that moment that God had blessed me with a great gift, which is that my own kind of personal array of psychosomatic symptoms are such that I can always call upon myself as an example to normalize this condition. So that is what I'm going to talk about today. I'm going to talk about psychosomatic conditions and what neurologists refer to as functional neurological disorders. And I'm going to concentrate really in the first instance on the disparity between our attitudes to psychosomatic disorders and disease and the services that we provide to people who suffer with psychosomatic illnesses versus diseases. So when I refer to a disease, I'm going to be talking about an organic pathology. And when I refer to an illness, I'm going to be referring to a perception of how one feels. And when I qualified as a doctor during my medical school years and in my early junior doctor years and probably into consultant years, I needed patients to complain in proportion to the amount of disease that I could find. And I had great difficulty dealing with people who seemed to complain disproportionately. And I think that this is something that many people in the health service suffer with. And I think the evidence is there. If you look at the journey of people with psychosomatic complaints through the health service, there's plenty of evidence to suggest that we all really are ill-equipped to deal with these sort of disorders. I think it's unfortunate that disability isn't really judged according to how a person perceives their disability or how disabled a person is on a day-to-day basis, but rather on a sort of notional ranking system that we've created for disease. So just to kind of illustrate some points around this, I'm just going to give you the story of a young woman that I met in the recent past. So this is a woman who was in her early 30s. She'd had a few illnesses throughout her life, but recovered from all of them. So she was essentially fit and well at the time that she had an injury that led to disability. She was working as full-time as a housewife. She had been working outside the home. She had a child. She was now working as a housewife. She was in her own home when she ducked under a garage door and was hit on the lower back by the door. She suffered a painful injury at the time, didn't go to the doctor on the same day, but did go the following day when she was in a lot of pain. Her GP arranged for her to have plain x-rays. The x-rays were fine. She was given anti-inflammatories and she was given an expectation that she could recover from this. Unfortunately, however, she didn't recover. Her symptoms progressed. She began to notice altered sensation in her legs. She was referred first to an orthopedic doctor and later to a neurosurgeon. What began with altered sensation began to be a perception that her legs were weak. Her legs became progressively more weak. And this progressed over a period of months until she was unable to walk further than a few yards, and she was largely wheelchair-bound. As it progressed further, she began to notice altered sensation in her arms, which also became weak, although not to the degree that her legs were weak. Now, during this time, she was being seen by hospital specialists who initially did MRI scans of her lower back, then her thoracic spine, her cervical spine. Over the course of about 9 months, she had about 5 MRI scans, various scans of her spine, and also ultimately a scan of her brain. It was only when she collapsed one day and had a seizure that she was referred to my clinic. I run a seizure clinic. When she came to see me in clinic, I felt it was very clear what was wrong with her from that first meeting. At this point, I want to immediately dispel a sort of a misunderstanding that I think doesn't necessarily exist in this room, but certainly exists in the minds of patients, which is that a diagnosis of something like a psychosomatic disorder is made on the absence of evidence, or it's made on the fact that she'd had 5 scans of her spine and those scans were normal. The diagnosis of functional neurological disorder in particular, compared to other sort of somatic disorders like pain, are made on positive features of the clinical examination and positive features within the clinical history, rather than on the fact that you just couldn't find a disease. Because as we all know in this room, there's loads of medical conditions for which there are no abnormal tests in which we know there is disease. So a normality of scan should never be the deciding factor in making this diagnosis. So in this young girl, for example, or young woman, I should say, for example, the issue really was that her anatomical pattern of weakness did not fit with any appropriate neurological anatomical pattern of weakness. There was a huge disparity between her objective findings and her subjective findings. Essentially, her weakness was anatomically impossible. Her weakness varied according to what position you tested it in. If you tested it sitting, lying, when she was attempting to stand, different muscles were weak. They weren't the appropriate muscles for an upper motor neuron lesion or a lower motor neuron lesion. There was a big disparity between the degree of weakness and the reflex and the plantars and so forth. So it was very obvious to me that she had a functional neurological disorder. She had a seizure during her consultation with me. I have the benefit that I've seizures, that's my specialty, so it wasn't very difficult for me to say that her seizure was what neurologists now refer to as dissociative seizures, what used to be called non-epileptic seizures. See, my voice is beginning to go now, but that's just... My next book is not about psychosomatic disorders, so I'm not sure how I'm going to explain this at the next talk I have to give. So basically, I was quite sure what was wrong with this woman, and I knew what was wrong with her because of the positive features of her illness, not because I knew that her scans were normal, and not because she was an anxious young woman. So what I did was I sat her down, and I gave an absolutely full and frank discussion with her about exactly what I thought was wrong. And obviously this is a discussion which takes a great deal of time. But even at the end of that discussion, it was extremely difficult for her to accept the diagnosis. First of all, she'd invested in 9 months of searches for an organic cause for her symptoms. And now, out of the blue, a doctor was telling her that the symptoms were probably psychogenic in origin. And this was something extremely difficult for her, and she perceived it, no matter how careful I was, as a dismissal. And of course, she's quite right to perceive it as a dismissal, because very often that is actually what happens to these patients, particularly when we're working in very specialized hospital medicine. It's now considered to be completely reasonable for me to say you don't have a neurological disease, therefore I'm discharging you. So in that sense, we do dismiss people once we have ruled out organic disease. Also, it's very important to note that I'm pretty sure I was not the only doctor who considered this diagnosis during her journey. And I think the evidence is there that others had thought the same, and the evidence is in the lack of urgency with which they treated her. If you have somebody with a spinal cord disease who comes to clinic and goes off their legs and they're in their 30s, and they progressively become paralyzed over a few months, you do not send them home. If somebody's having 10 seizures a day and you believe they have epilepsy, you do not send them home. So there was something very telling in the lack of urgency with which this young woman was treated. So the question I want to kind of ask is, why are we so reluctant to be upfront about this diagnosis, and why aren't we more honest with our patients? I think it's particularly important when you consider that there is one single thing that has most influence on prognosis in people who have somatic disorders, and that is speed to diagnosis. So the sooner this diagnosis is addressed with the patient, the better chance they have of getting better. And the 9 months that this young woman had spent on her journey to getting a diagnosis was slowly eroding away at the likelihood that she would recover. The other things that improve your prognosis is if you're not invested in an organic cause for your symptoms, if you're not already being treated for an organic cause for your symptoms, if you are still in work, and if you're not dependent on social services. So in the 9 months that this woman had been sick, she'd had so many scans that she had become convinced there was an organic cause. Her husband had had to take time off work and then lost his job caring for her. So after this degree of 9 months, this family had lost so much that it was going to be incredibly difficult to reverse that again for them. So as I say, I'm pretty sure other doctors suspected the diagnosis, so why didn't they raise it? I wouldn't say it is a criticism of them. I had this problem also in the first instance, which is that it's quite a frightening diagnosis to raise. First of all, we as doctors, it begins in medical schools. We are trained to look for disease. So basically, that's what we do on the wards when we're students. We go around listening to heart murmurs and, and also looking for upgoing planters and so forth. And we have no interest really in somebody who's got a pain that we can't explain. We've got no interest in someone who doesn't have a disease from which we can learn from. And unfortunately, that's how we're trained as medical students, and it's important. We need to gather that factual information. But unfortunately, somewhere in there, people who suffer without disease are being dismissed, and that continues into medical practice. And I'm not sure it applies so much to GPs, but certainly in hospital medicine amongst specialists, the sort of what we are on is a relentless hunt for disease, and very often once we have ruled out disease, we consider our jobs to be done. The other problem really is that I think we think that psychosomatic disorders are less serious than disease. So we know what we're going to be punished for, and we know what makes people angry. And that's if you say something is psychogenic and then it later transpires that that person had an underlying disease, whereas the opposite mistake is much less likely to be punished. So I saw a patient recently who, a very young patient, 19, and his family were really directing his medical care. And he had multiple medically unexplained symptoms: abdominal pain, joint pain, shortness of breath, and ultimately then multiple neurological symptoms. And I again saw him when he developed seizures. Now, over the course of several months, the doctors at the start were looking for organic causes for his abdominal pain, but became convinced after the first few investigations that there was unlikely to be an organic cause. But very much under pressure from the family, they continued to carry out invasive investigations. So that over a course of several months, this young man had multiple sort of endoscopies, radiation-loaded treatments, laparoscopies, invasive investigations before he was referred to a psychiatrist. There were multiple complaints to the hospital about the care of this young man, but all of the complaints were directed to him being referred to psychiatrists or psychologists. And none of the complaints were ever directed towards all of the unnecessary invasive investigations. Because doing scans, even when we secretly know they're not necessary, and doing invasive investigations is considered as taking a problem seriously, whereas referring someone to a psychologist or a psychiatrist is perceived as not taking a problem seriously. And I think that's an attitude we really need to change. I now work in a very sort of rarefied environment where I see people at quite distant down their journey with seizures. So people have been to probably lots of specialists with seizures. I work in a unit where I can admit people for prolonged periods of time to witness their attacks, which gives me the opportunity to make firm diagnosis. It would not be unusual at all for me to tell someone who'd been told for the last 10 years that they had epilepsy, and now I'm telling them, no, you never had epilepsy, you have dissociative seizures. And what I'm waiting to happen, and what will never happen, is that they will go back to that original doctor and say, why did you say I have epilepsy? There's no anger in mislabeling something as a disease, because that really is just perceived as the kind of mistake people can tolerate, whereas the opposite mistake is not tolerated. The consequence of that is that we're being constantly pushed towards making a diagnosis of things like epilepsy just in case, because we perceive that to be the biggest mistake to make, is to miss that type of diagnosis. That brings me to the question of, is that the biggest mistake, and what harm are we doing by missing people with a psychosomatic diagnosis? So there is a perception that if you have someone, say, with seizures, and you miss a diagnosis of epilepsy and call their problem dissociative seizures, that dissociative seizures are less serious. Dissociative seizures are less likely to kill you. That is the only good thing I can say about them. In every other sense, they're harder to treat, they're more aggressive, they're more frequent, and they're more problematic. So non-epileptic attacks, dissociative seizures, are way, way less common than epilepsy, and yet they're hugely overrepresented as hospital admissions. 25% of people who go to the intensive care unit with status epilepticus actually have pseudo-status epilepticus. If you have non-epileptic attacks, you'll probably have dozens of attacks a week that last longer. So in every sense, these seizures, which are perceived to be less urgent, are much more life-destroying, even if they're not quite as life-threatening. And the longer we go to make the diagnosis, the harder it is to reverse the diagnosis again. Telling the person the diagnosis is the first therapeutic step, and that's why I'm really emphasizing this point. So if within 24 hours of telling someone they have dissociative seizures, if you do it right, the seizures can disappear. 3 months after telling someone the diagnosis, even if you don't refer them to a psychiatrist or a psychologist, the seizures will have gone into remission. So learning how to have that therapeutic conversation with somebody and to present this diagnosis to them in a way that they can accept the diagnosis is part of making them better. So for example, in the young woman that I was talking to you about earlier, I told her the diagnosis, and at that time she was having 10 seizures a day. She was not one bit happy with the conversation we had. She struggled to accept it, but she listened to it. Following that, I arranged an urgent admission to the ward for her because I was very concerned. She was supposed to be looking after a young child, but unable to do so, and the family had lost so much. I remember being very concerned about admitting her to the ward because I know that other people don't perceive this to be an emergency problem, whereas I did. It took a week to get her into the hospital, and in the week between my giving her the diagnosis and her coming to the ward, the seizures had stopped. I had done nothing but tell her, and she hadn't even particularly liked it, but something had sunk in on some level that brought the seizures under control, and then an intensive course of physiotherapy got her up walking again. I'd love to tell you that that improvement was sustained. It wasn't. I had sort of touched on the problem, but then there was a 6-month wait to see the psychiatrist to try and get to a deeper level with the problem. So she did relapse. But it's interesting to note the impact you can have after 9 months of persistent symptoms. The other issue really about talking to patients is how upset and angry they get. And I think they're quite right about that. And the first thing I do is try and dispel the popular kind of misunderstanding surrounding these medical problems. So the first thing is really about the conscious intent. So that was certainly my sort of feeling when I started dealing with these disorders, was to worry way too much about how much insight people had into the problem. So I have written in the past about a woman I saw who was profoundly blind, but there was no organic pathology to explain it. And I noticed over the course of her admission, if you examined her on confrontation, she was profoundly blind, but in distracted moments, she'd reach out and pick something up. And I really started misinterpreting these kind of actions as meaning that she could see, or perhaps she wasn't admitting that she could see as much as she could see, for example. And at the end of that particular woman's admission to hospital, she did something very bizarre, which she gave me a card with a picture she had drawn herself. And the card had a tree and flowers on it, and they were all drawn perfectly. The colors were appropriate. And at the time, I couldn't interpret it, how a blind woman could draw a picture. But I know that I had sympathy for her, but I believe that her insight was greater than she admitted to. And I took this sort of thinking into clinics where I examined people who were profoundly paralyzed. And when I went to write my notes, I would secretly watch them from my corner of my eye to see if they were moving when I wasn't paying attention. And you know what? Sometimes they did move when I wasn't paying attention, or when they thought I wasn't paying attention. But again, this really was an issue of me thinking that that implied insight. I've realized over time that it implies the opposite. Somebody who is pretending to be blind, someone who's pretending to be paralyzed, a blind woman walks around with a white stick, creating a pantomime out of that pretense. These disorders require attention. So for you to have an anxious tremor, The tremor is sustained by the attention and concern surrounding the tremor. The paralysis is maintained by the attention, the negative attention that you're paying to your limbs. And in distracted moments, there is variability. And that variability is not an indication of intent. It's just a feature of the disorder. And when that woman drew me a picture, there really was not an act as innocent as that, because it really was, it implied the unconscious nature and not how I had interpreted it. The other problem is people's concepts around the cause and the mechanism. So in the past, we used to really always emphasize the kind of idea that stress and a particular trauma or abuse has led to these kind of disorders. It is absolutely right to say that people who have things like dissociative seizures or functional neurological disorders are more likely to have suffered significant abuse. 30% of people with dissociative seizures have suffered sexual abuse. That means 70% haven't. It used to create a really big problem between doctors and patients. You'd see someone who had these kind of unexplained medical problems, and I would find myself searching for the stressor in their life. And this creates a situation between doctor and patient where you're going, there must be something, and they're going, there's nothing. And that's a breakdown of relationship that will never move forward. In fact, there are multiple ways that this can develop that don't necessarily require any preceding trauma. Again, I will give you another example from my own dysfunctional self. And basically, so last year I had to go to the States to do radio shows. I was absolutely witlessly terrified. And just before I went, I got laryngitis, which is something I've had periodically throughout my life, where if I get a really bad cold, I lose my voice every 3 years or so. And usually what I do is I just carry on, because you can't cancel work, as you know, so you just keep going. But this time, aware that I was going to have to do these radio shows, I sort of coddled myself, and no throat has ever been as carefully cared for as my throat was in that week, or as thought about as much. I was so focused on it, and I did what I never do, which is I didn't go to work because I was resting my voice. And then essentially for a week, I didn't speak at all until I was struggling to speak. By the time I flew to the States, I could hardly speak. The night before the first radio show, I went out to dinner with my publisher, and basically I couldn't get a word out, and I was just super anxious. And I walked into the radio show having not spoken a complete sentence in a week, and the on-air sign came, and I miraculously recovered. It all ended happily. But the point is that this is actually a really common thing that happens to my patients. Basically what happens, very often these things can start with something like an injury, for example. So it's not always about a psychological trauma. What sometimes happens is this is an illness of perception, or an illness of belief, or a manifestation of the attention that you pay to your body. So for example, what often happens is somebody injures a limb. They have an expectation of how that should recover and the speed at which that should recover. You don't usually walk around thinking about the way you're walking or thinking about how your leg feels. But the minute you do start thinking about it, it starts feeling strange. And that sort of paying attention to different symptoms can really magnify those symptoms. So sometimes functional disorders develop because of that sort of attention, rather than being a feature of a psychological trauma. So for that reason now, when I meet a patient, I will ask about stressors and trauma, but I won't overemphasize the point if they're resistant to it. If there is something, it'll come out in the wash. If there isn't something, it's not very productive for me to push it. The other thing I find very useful is to present this as a sort of continuum of the normal experience, because it is normal for us all to have physical responses to stresses. That happens to all of us frequently. So I will always bring up those common examples with patients to try and help them to understand how this can happen. So for example, I will say to patients, when I'm frightened, my heart beat goes up to 130 beats per minute. Now, if that was happening to me, would you say to me, you're doing that on purpose? Would you say to me that you're imagining that? Would you say to me you could stop that if you wanted? You would appreciate that my heart rate has really gone up, but you would also appreciate that I don't have a heart disease. And you would believe that perhaps in time I could learn to do things differently to bring that symptom under control. So I think it's really helpful for people to think about it that way, because it really worries patients that they're going to be accused of doing something on purpose, or that this is something so unusual and impossible that it's only affecting them. And I think, I'm not especially Freudian, but I also think it's very interesting, something that Joseph Breuer wrote in the book that he wrote with Freud, which studies in hysteria, which is that, every single voluntary movement begins with an idea that tells your muscles to contract. So why shouldn't it be the case that an idea could also hinder movement? So I think that these conditions are really quite logical when you think about them. And if you present the common examples to patients, they find it much, much easier to accept them. Now, I'm pretty much out of time, so I'm going to just do a whistle-stop tour of what I think the solutions need to be. It starts in medical school and textbooks. So essentially, in medical school, this diagnosis needs to be raised up in the conversation. 2 commonest reasons to go to a seizure clinic: epilepsy, dissociative seizures. So they should be the 2 things talked about most, whereas usually things like dissociative seizures get put right on the end of a list after a variety of things that we never see. I have a nephew in medical school. He loves to ask me questions about neurology so that he can go to his tutorials and without studying and pretending that he knew it all. And basically, but I can tell from my discussions with him that people who have memory impairment, he had a whole tutorial on that. It was never mentioned that a common reason why people suffer with memory problems is poor concentration for psychological reasons. So we need to raise this conversation in medical school. We need to improve ownership. People with neurological complaints that are psychosomatic still have neurological complaints. So you need shared ownership between the medical doctors and the psychiatrists. I have lots more to say on the matter, but time is up, so.
I was just going to direct you to that water. Suzanne O'Sullivan is a consultant neurologist at the National Hospital for Neurology and Neurosurgery in London. She qualified as a doctor in 1991, but also took a creative writing MA in Birkbeck in London a couple of years ago, resulting in her very fine book, It's All in Your Head, True Stories of Imaginary Illness. Listening to you speak there, it struck me how much you use the word serious in relation to what you're talking about. And with psychosomatic illness, has there often been an assumption that doctors are not interested in it or don't know how to respond to that? And is that ultimately because there's a lack of training around how to deal with it?
Yeah, I mean, first of all, with regards to the lack of seriousness or the attitude to it, so if we had 2 people in this room now who had recently become profoundly paralyzed, one through a spinal cord injury and one for psychosomatic reasons, one of those people would be in a rehab unit, and one of those people wouldn't even be admitted to hospital. And that is, I think, because we really have an underlying belief that they're not really paralyzed. Now, as long as you're in a wheelchair and you can't move, you're really paralyzed. These people are less permanently paralyzed, and surely that is a reason to make this more of a focus for attention than less of a focus for attention. With regards to medical schools, I think it may be improving now, but certainly in most medical schools, this is really not discussed. And you've got to remember, I'm talking about neurology, of course, but 30% of people who go to any medical clinic have some sort of unexplained somatic complaint. So this is a problem for all of us. So we will actually spend every single day, 1/3 of our clinics will be people with somatic disorders, and yet most of us will have had no training in it. It's unbelievable. So it really has to my mind, start in medical schools and in textbooks. Also, sorry, it's very hard to shut me up once I start, but I apologize. And basically, because now you're opening up all the things I forgot to say. The other thing is, so again, I say, 1/5 of people who go to an epilepsy clinic have dissociative seizures. But until a couple of years ago, if you went to the American Epilepsy Society, any neurological meeting or epilepsy-related meeting, you never heard dissociative seizures discussed. How could it be that something we spend 1/5 or 1/4 quarter of our time doing wasn't even discussed in our professional journals or professional meetings. So it's been traditionally neglected as a non-problem, but I do believe it's changing.
Do you think also that there is, say, if you have psychological illness here and you have physical illness here, is there a Venn diagram in the middle where there's a limbo, there's a no man's land where the two absolutely overlap? They're not two distinct things.
Well, see, this is the problem, is that they are too dichotomized. I mean, essentially the patients I'm seeing have physical symptoms. So it's of no help. That young woman that I saw, that I described to you earlier, it's of no help at all to her if I just discharge her to a psychiatrist, because her problem is she can't walk. So that's why we need so much better ownership between these people. So I think traditionally, neurologists have discharged people, and I think other specialists do it also, once they have ruled out disease. Whereas really what we need is better MDT teams, so that you've got your neurologist working with your physiotherapist, working with your psychiatrist, working with your psychologist. These are physical problems and psychological problems, and people need to be approached in two ways.
How do you handle it as a neurologist when you encounter somebody who is utterly against the idea that any of their symptoms are in their head, and that they're convinced it's their body, it's their stomach, it's their heart, whatever it is?
Well, usually what I try to say, because I do see people who are extremely resistant to the idea, I ask them to approach this medical problem in exactly the same way that they have approached the potential organic diagnoses. So normally, you go to the doctor with a particular numbness in your leg and you say, well, is it a peripheral nerve? Is it your back? Is it your brain? Where is it coming from? And people will have a series of investigations trying to figure out which part of their body it's coming from. And they'll try different procedures to try and make it better. And I will say to them, well, this is part of that process. When we're trying to decide what's wrong with someone, we say, could it be this or could it be this? You've tried these organic kind of routes, and it has not made you better, and it's not given you answers. I'm not asking you to invest in the idea. I'm asking you to continue the process we've already started by going down the path of this as yet another possibility, and it may or may not work. And most people will consider trying kind of psychological interventions, but you do have to be invested in it for it to make a difference. But I think it's also very interesting, the different levels of evidence and the different rules that people apply to these disorders. So we would, as doctors, constantly be making diagnoses without single diagnostic tests. I tell people regularly, you have migraine, you have epilepsy. I don't have tests that prove that. I've figured it out on the story. Not one of them ever says, I don't believe it because you haven't given me the evidence for it. But when it comes to psychosomatic conditions, people want evidence. That's related to stigma, so it's the stigma we have to work on. Similarly, when it comes to treatments, I treat somebody with epilepsy, I give them a tablet, it doesn't work. They don't come back and say, I'd like a better diagnosis. They come back and say, I'd like a better tablet. Same thing happens with opposite happens with psychosomatic disorders. They go to the psychiatrist, they don't feel better, they come back and say, well, the diagnosis must be wrong. So the stigma creates a different attitude to these, to the way we approach these disorders. So I try and convince people to use the same thought processes with psychosomatic disorders that they would use with the disease process.
Do you think there are certain kinds of people who are more predisposed to it, or is it less person-based or more event-based? Why someone would present with a psychosomatic illness?
Yeah. I mean, it is true to say that there are people who are more susceptible. I don't like getting into a conversation about sort of saying it's a certain type of person, because it's a very problematic conversation, because it is an argument that people say, well, I'm not that sort of person. There are people who are more predisposed. People with kind of neurotic, anxious personalities are more likely to get these disorders than other people. But create the right set of circumstances, and this can affect anybody.
Rachel is probably going to talk a little bit, I think, about words. How do you treat something that doesn't necessarily have a name or isn't one thing?
Yeah, I mean, that is also a problem, yes, because I'm talking about the neurological side of things, but yes, it's a spectrum of symptoms. I think what we really have to do is create specialist service for this, so it's a well-defined disorder. What this needs to be is an illness like any other. So at the moment, it's kind of a non-diagnosis in patients' minds. And although there was a study in Scotland called the Scottish Neurological Symptom Study that showed 30% of people who go to neurology clinics have psychosomatic conditions. So what we need to do is create the same specialist structure for those that we would have for MS, for epilepsy, and other diseases.
You've been working in this field for a really long time, and obviously I suspect pre-internet, pre-social media, pre-smartphones, all of that stuff. Have you seen that technology and our almost switch-onness, our distractedness, our plugged-inness, the need for affirmation people get from social media, do you think that has had an impact on this area?
I really don't, actually. I think the only thing that the way it's made, it hasn't increased the frequency of this. I mean, this has been a condition which is well described throughout history, and the only thing that things like the internet and changing eras make a difference to is how we attribute our symptoms. So I remember when I was a junior doctor in the 1990s, people used to come in and ask me if they had candidiasis was a very popular concern at the time. So people would, I remember seeing a lady in casualty who was convinced she had candidiasis, and I haven't been asked that in donkey's years. So basically, I think what happens with social media and media is that it shapes how we attribute these disorders, but it hasn't changed the way they manifest. And it hasn't changed the frequency of them. It's just given us kind of new labels.
The final thing I want to ask you before we hear from Rachel is the cost.
Yeah.
I came across a figure from the US, it's about maybe a decade or so old now, which said that it costs the US something like $250 billion a year. Is it putting a massive strain in terms of money on the health service?
Yes, I mean, it's so they did a study in London looking at 3 GP practices where they only chose the 3 most severe, or they only chose the most severe tier of these patients. So 1% of the GP population, and look at how much they cost the health service. And they found in these 3 GP practices 227 patients. And each of these 227 patients had each had at least 20 visits to their GP in a year. And each of these 227 patients, between them, they'd have over 1,000 hospital visits. And they had cost the NHS about $500,000. So when they extrapolated this to just the severe patients in London, that came out at 115 million. But that wasn't including the 30% of people, the rest of the UK, and the less severe group. So this is very costly to the health service. And if we dealt with it better, I mean, I see a lot of people now who've been sick for 20 years, and I can't really make anyone better after 20 years, is the honest truth of the matter. What I can do is help them to approach their symptoms differently so that their health utilization is different, so that they can stop looking for invasive investigations. So I think there is also a cost saving to be made here.
Suzanne, thank you. I wish we had so much more time, half a morning, to talk about this.